Hi, everybody. It's Professor Miller. This lecture is going to cover the innate immune response and inflammatory response. I'll have a separate lecture on adaptive immunity, but it's really important to make sure you have a good understanding of the innate immune system, the inflammatory response, and adaptive immunity. A lot of this will help provide that foundation for future disease states that we actually talk about. And I'll try to explain it as we kind of move through and how it relates essentially as well. So make sure that you obviously run through this and have a good understanding of it. It might be a review for you. You might remember, portions of it, but I'm just going to go through each section essentially. So in terms of immunity, we actually can divide it up into basically three responses. Your first response or first line of defense is obviously your innate or your natural or native immunity. And really that first line, we actually look at it more of like those physical barriers or mechanical or chemical barriers. And these are things like your skin, your mucosa in your GI tract, the pH of your stomach, and I'll discuss that in a few. The second line of defense, which really is actually a portion of that first line of defense or your innate immune system, is inflammation. And as I mentioned before, the inflammatory process is heavily linked with a lot of different disease states. So, when you look at it, it's not just, for disease prevention or infection prevention. There's other, obviously, things that it's linked with too. The third line of defense is your adaptive immune response, or we sometimes call it your acquired or more specific immune response. This is where you develop antibodies, for protection, for long-lasting protection, essentially. So your innate is that first defense. It's not, it doesn't have memory like your adaptive immune system does. However, they're very heavily interconnected. Your innate immune response essentially works with your adaptive immune response. And I'll, explain that too as we go through. But the big thing, just remember your first line is innate and those barriers essentially that are in place and inflammation. This is just a good image, depicting the difference between your innate and adaptive and obviously the timing. So once again, it's that first point of entry of bacteria or an injury. Doesn't even necessarily have to be, a bacteria there. Even if you have an injury, that inflammatory process and all that, once it's exposed, essentially begins. So it's those first few hours, essentially, that this kicks in. It's pretty immediate. And there's different things, like at the very top, it talks about epithelial barriers. So that's just things like your skin and factors like that. And then you have things that are like phagocytes, your complement system, which I'll discuss too, dendritic cells, and your dendritic cells actually have an important role in actually presenting antigens essentially for your adaptive immune response, and that's how you develop antibodies. So they really are heavily connected. But once again, that adaptive response is a later response, and it's more for long-lasting antibody formation essentially. And we'll discuss that separately. So that first line of defense essentially is really those barriers that are in place, like your skin, the lining of your GI tract, your genitourinary tract, your respiratory tract, just basic things, sloughing of cells, coughing and sneezing. And remember when we actually talked about changes in the respiratory tract with like hyperplasia or dysplasia and things like that. And this is an example how you would lose that first line of defense. With chronic smoking, they get cellular changes there. And obviously, if you lose that type of cellular function, they reduce the ability to bring up mucus, and that cilia essentially don't work well. So that's another reason why like a smoker would be more predisposed to, developing respiratory infections. Just to give you an example, urine, there's certain bacteria that thrive more in a certain pH of, your urine, or even in your GI tract as well. Based on it being acidic or alkaline, essentially. So it can definitely affect, the bacteria thriving in a certain environment. Vomiting, upper GI, the acidic environment. So that's just another area that actually protects you against invasion of bacteria, parasites, viruses, etc. Mucus and cilia, those things are external barriers, essentially, that help prevent infection. When you look at epithelial side-derived chemical barriers, so obviously your epithelial cells are things like your skin. Your saliva has a lot of enzymes and stuff like in it too that can actually protect against bacteria. Same thing with your tears, your earwax, sweat, mucus. All of this stuff has protective enzymes and antimicrobial peptides in it to protect against bacteria evasion, essentially. You also have your normal microbiome, and this is actually really important. And I'm sure everybody has probably seen this at one point or another with their patients, but Certain areas of your body, whether it's like your vaginal area, your respiratory tract, or your GI tract, obviously have normal bacteria or normal flora. You'll hear that term used often, that essentially live in that area. Becomes colonized with certain bacteria or fungus, essentially. A good example is in the vaginal area. It's normal to have a tiny bit of yeast in that area. However, when you think of things like when we give antibiotics, it wipes out that normal flora. So you get rid of all that good bacteria that keeps that environment stable, essentially, or free from pathogens that cause disease. So when you give them antibiotics, that's a great example. That's why you tend to get an overgrowth of yeast. Like women will have, if they're on a hefty dose of antibiotics, it's not uncommon for women to get like vaginal yeast infections. And it's because we alter that normal bacterial colonization essentially in that area. And the same thing can be true to like your GI tract, which sometimes they end up with diarrhea and things like that. You think about antibiotic therapy. Same thing too, there's different chemicals essentially, or the environment in your intestine, like the production of ammonia or phenols, and that inhibits bacterial colonization. So anytime we alter this, obviously you're putting the patient at risk for an infection. So prolonged antibiotic treatment essentially get an overgrowth of bacteria. So that's not uncommon. It's always something to look out for. This is an example of those external barriers and things with your epithelial cells that you can see. Like once again, your nasal mucosa, secretions, and your oral mucosa, your respiratory tract, like your cilia that are there. Even, like I already mentioned, the vaginal flora and lactic acid. So that's why, you've heard about probiotics or even yogurt that has lactobacillus in it. And, it's to promote a healthy microbiome, essentially, in patients. So that's why we recommend things like that. Acid secretions already mentioned, the pH of your urine. These are just examples, essentially. Technically, the second line of defense is when we have that inflammatory response kick in. It's technically the first immune response to injury. So it's the first time the immune system's actually kicking in, besides, those barriers that are there. Remember that your first line of defense, or your innate immune system and inflammatory response, are non-specific, meaning that it's not targeting a certain virus or targeting a certain bacteria. That's your adaptive immune response, which is actually very specific. It's caused by a variety of different mediators or materials. And it can be things such as tissue trauma. It doesn't necessarily have to be invasion of a bacteria, like I already mentioned. It could be chemical injury. Just think of any injury or insult to the skin or any type of, injury you see in a patient. This is the normal response that occurs right at that very beginning. And once again, obviously, too, it occurs with infection as well. It can be with an immune reaction, ischemia, anything like that. So obviously, when you're looking for inflammation in your patients, it's those common manifestations that you typically see. The redness, the heat, the swelling, pain, or loss of function. So those are those common symptoms that you will see. Heat, redness, swelling, tenderness, pain. If you just think of an injury to the skin, that's that initial response. And this is actually from your first innate inflammatory response, essentially. So you get changes, essentially, and you can have changes with the capillaries, like those the capillaries essentially widen, and then there's an increased permeability there. So that's why you get swelling, because that fluid starts to permeate into the tissues. Attraction of leukocytes, so you start to have, those leukocytes like neutrophils go to the area of injury. And all of these factors, like, the fluid into the tissues, the neutrophils, that's essentially, too, what, promotes, obviously, tenderness in the area as well. And then, obviously, if it's a massive infection, you can even have systemic responses. You can get fever and even see, like, leukocytosis when you look at your patient's lab values. Commonly at the very beginning, you'll see a rise in neutrophils, and that's not uncommon with, a significant inflammatory response in patients. So once again, it doesn't necessarily have to be related to an infection, but it, a lot of times that's what we kind of relate it to. But it can just be from, a massive inflammatory response in the patient, essentially. So I already kind of mentioned you get that vascular response. So there's, it'll dilate. Then that increases permeability there. So then you get edema in the area. And then you also it promotes that, the movement of white cells, essentially, from the vessels to the area, of injury, essentially. And really, the whole goal of this is actually to contain that area, and it's really to prevent, further damage to other areas of tissues, and really to truly attack that infection if there is an infectious agent there, and limit it essentially. So it's kind of meant to contain it. However, it does, like I mentioned, initiate that response to your adaptive immune system. They're heavily connected, and that's what stimulates that second, immune response, or I'm sorry, your adaptive immune response. And once again, it's to initiate healing. So healing obviously begins right at the very beginning. So you'll see things like histamine, and as we mentioned before, histamine is one of those, chemical mediators that's released naturally by your body. But histamine has that effect of having like swelling. So even if you think about like a hive, a lot of those reactions, like a hive from, allergic response, is from histamine. So histamine promotes this, environment of swelling, vascular permeability, and chemotaxis, where you have all those, inflammatory mediators essentially go there. Same thing with prostaglandins. That's another thing that's usually released as well. And prostaglandins, once again, on a systemic level, remember, it can be linked with fever, and pain as well. So it can be, related to that too. So you also have, you have the clotting factors that are involved as well. And I'll discuss that in a few slides. But, obviously that too is to contain, if you have a wound there, it's obviously to stop bleeding. So that's another significant portion of the innate response. And then you have, those chemotactic factors where you have like phagocytes that go to the area. And that's once again I'm sure you remember what phagocytes are, but, their main function is essentially to attack and engulf that, any infectious organisms and get rid of them essentially. And that's why we end up with, cellular debris. And even like when you think about like a wound, that's why you end up with like that pus, or, if there's an infection, you start to get exudate, and that's actually because of, phagocytes basically getting rid of debris, whether it's, an infective agent or not even, it tries to clean the area up essentially. So this is just a good way to kind of look at it. When you look at cellular injury over on the left, or pathogenic invasion, what happens with the innate immune response, you get a combination of factors. One is mast cell degranulation, and we'll talk about that too. But you also get activation of the plasma systems, and these are really a combination of three systems that work together. And it's a cascade event, so you have the complement clotting and kinin system that work essentially kind of together. And I'll go through those with you too. Release of cellular products is another thing too. So this, again, all these factors come together, and that's what's stimulating, this response of, redness or heat, edema, pus formation, clots at the area, and even stimulation of nerve endings. So that's why they have pain there, obviously, too. So it's just a good way to kind of look at it as it flows through into a clinical presentation, essentially. So the plasma to protein systems, this is going to be kind of confusing. There's a lot of details. Like when you look at your book, I tried to find one that was a little bit less detailed and kind of straightforward in terms of a chart. Because obviously there's a lot of different molecules within the complement system, and I don't expect you to memorize those like C3b or C3a, but I just want you to get the overall broad general concept here. And I'll kind of try to point it out to you as I go. But these plasma protein systems essentially are what are a huge portion of your innate immune response. So you have your complement system, which basically gets activated, and there's different pathways. Once again, I don't expect you to memorize individual components of the pathway. I want you to understand like the main end result here and what essentially it does. And I'll go through that in a minute. And then you have the clotting system, which obviously I'm sure you all are well aware of what the clotting system does and what its use is for. For clotting, obviously to prevent bleeding in that area. But you also have the kinin system, which basically the big one that's heavily integrated within the kinin system is bradykinin and histamine. So those are the two that you'll commonly hear a lot about with bradykinin and histamine. But this tends to promote a lot of swelling or permeability, increasing that vascular permeability there. And this stimulates pain and swelling essentially. And I'll go through these. But from a broad perspective, if you really think about it, like think of a patient, I'm sure you're well aware of patients that have had, a genetic clotting disorder or a defect in their complement system. Like they may they may not produce those mechanisms in their, or the typical response in the complement system. May be deficient in areas. And if you think about it from a broad perspective, you can understand how these patients are at risk, obviously, for further infection or bleeding. If you have a clotting disorder and you're not producing what's, factor 10 or factor 9, if you have a deficiency there or an alteration, you can see how in the end it can obviously affect wound healing and infection. Just to kind of put it in a clinical perspective here, essentially, and how it actually affects them. As I mentioned, it's all sequentially activated. It's definitely like a cascade event, and I'll kind of go through these each separately with you. So your complement system, once again, has different pathways. In it, it's heavily, or has a heavy integration with like those phagocytes, your mast cells. So it's really kind of what's triggering that response with mast cells and histamine release and all those. And basically leukocyte filtration to that, or migration to that area. So really you have these different pathways, like your classical, and that may be activated by like your acquired immune response or certain proteins, or the lectin may be activated by certain carbohydrates that are on bacteria. These are just examples. The alternative may once again be activated by gram-negative bacteria or fungus, essentially. So it can get activated from different mechanisms, essentially. But once again, like you might hear about C3, but like if you had a patient that had a deficiency, this can be affected, obviously, and then they have a reduced immune response. But it's really a potent defender against infection, essentially. So once again, in the end, you get leukocytes that migrate to the area, and they even actually attack, damage or damage the bacteria, essentially, at the micro level, essentially. With your clotting system, obviously, you have different factors that cascade event with your clotting system, and we'll talk about that in hematology. But really, what it's doing is making a fibrous meshwork, essentially, at that injured or inflammatory site. And really, it's to contain the area, prevent spread, basically to stop bleeding. I'm sure you pretty much know that. And it also actually lays that framework for repair and healing, essentially. But fibrin is a huge component of this, obviously. But basically, essentially, it's to kind of contain that area. So this is essentially your clotting cascade. Your kinin system basically functions to activate and assist in your inflammatory cells. So once again, these all work together. The big one is bradykinin. You'll hear this a lot when we talk about different disease states, or even certain treatments with medications can trigger release of bradykinin, and pose issues in the patient. But it performs essentially very commonly like a histamine type response. And once again, they get that vascular permeability, and that's essentially what causes the swelling, the pain, around the area of injury, and also obviously triggers pain in the patient as well. So when we look at the big picture here, obviously this is just an example, bacteria and pathogens entering the wound. So you have that release of platelets from the blood and basically going to that site. And then you have mast cells, which I'll talk about too in a minute. These are different, they release different mediators that, affect the area as well. You have neutrophils and phagocytosis, and then you have macrophages, basically, that are involved in tissue repair. But obviously, this whole process works together. So it's just an example of how it migrates out of the vascular system over to the tissue and essentially attacks that infectious area, or kind of localizes it, essentially, as best it can. When you hear about mast cells, this obviously is part of your innate immune response, but what they technically call them like a cellular bag of granules, and it's located in the connective tissues, very close to the blood vessels. They're present in multiple tissues like your skin, your digestive lining, your respiratory tract, but they contain, in these granules, essentially, they contain things like histamine or cytokines or chemotactic factors. So these are all those first responders, essentially, during that innate immune response. Obviously, it has a big impact on that. Basophils is another one, too. They probably function, they don't know exactly everything about it, but they probably function a very similar way as mast cells. So once again, it's starting that initial, chemotaxic response essentially to that area. In terms of mast cells, they release chemicals in two different ways, and I have that on the next slide, but it's through mechanisms of degranulation or synthesis. So two different things. They either release the content from the mast cells or they actually produce new mediators in response to like an injury or a stimulus there, essentially. This example on the right with an image is actually, it kind of puts it together well. But when you look at mast cells, they basically have a huge component in histamine release. And it also has a big component into releasing prostaglandins and leukotrienes. As we move forward, and actually when you get into like pharmacology, we use a lot of medications that actually target these. So things like antihistamines, prostaglandin inhibitors, medications that work on leukotrienes. A good example where this is heavily integrated within like a disease state is looking at like, for instance, something like asthma. Asthma's very, very inflammatory. So that's the main pathologic process behind it is acute inflammation. And it's because of factors like this. So like when we talk about respiratory things like asthma, it's because of release of typically a lot of times like allergies go hand in hand with asthma, but it's usually because of like the swelling from histamine. Or there's leukotriene release, and once again it causes swelling in the area, and then they get constriction with it. So like we use leukotriene inhibitors, like one is singular. We'll use singular for asthma, and it's targeting leukotrienes. Or you just think of general allergies. We use antihistamines, and it's because of this inflammatory response. So when you think of inflammation, it's not just necessarily like an acute injury or a tissue injury, or a wound, it's other things too. So that's why I said it's important to kind of understand what these, factors do essentially. But we'll talk about histamine, further as we move into further disease states. But it basically causes, rapid constriction of large vessels. However, it dilates those little capillary venules essentially, and that's what's causing that, or increasing that capillary permeability. So that's why you get the swelling with it. And we'll also talk about different histamine receptors because there's H1 and H2. H1 is the one that's inflammatory, so it's pro-inflammatory. And these are present once again in the smooth muscles of your bronchi. Once again, that's why it is heavily linked with asthma. We'll also talk about when we get into to GI, you have your H2 receptor. Your H2 receptor is present in your parietal cells of your stomach or the mucosa of your stomach. It has an anti-inflammatory properties to it, but H2 receptors heavily regulate your secretion of gastric acid. So really, in terms of like the inflammatory response, we really look more at H1 because that's the one that's more pro-inflammatory. But we'll talk about H2 as we kind of get into further. And once you get into pharm, it's the same thing. We use H2 blockers. Remember, if you think about an H2 blocker, we use it to reduce acid secretion. And histamine, that's why I was mentioning about histamine, using antihistamines too, just to kind of put it in perspective with a disease state. And I already mentioned this, these are more late responders too. So you also get, at the very beginning, you have all those mediators like neutrophils that go to the area or phagocytes that kind of contain it. So these are a little bit later. It's still part of your innate response, but you kind of get this like an after effect essentially. And leukotrienes, I already mentioned, it's very similar to histamine in terms of the response from it essentially. But once again, these are released from mast cells. Prostaglandins, same thing. They also induce pain, but they're very similar to leukotrienes as well. And I think we mentioned this before when we even talked about pain, but prostaglandins, obviously, we target this for pain management, whether we give them an anti-inflammatory or aspirin, or even, things like acetaminophen. And it, basically we're blocking that synthesis of prostaglandins. So that's basically helping with pain relief essentially with it. Platelet activating factor, it's very similar to leukotrienes and platelet activation. So that's another thing that can occur from mast cell essentially, from synthesis of mediators. So they either synthesize mediators or they degranulate and release histamine and all that. This, I'm sure you probably already know what phagocytosis is, and basically that chemotactic gradient and basically containing that infection. Usually it's neutrophils and things like that you'll see with it. I'm pretty sure you know what phagocytosis is by now. But basically they're engulfing those pathogens and destroying and digesting them essentially to rid them from the body. So typically, when you hear about phagocytes, there's obviously different ones, and your monocytes basically they turn into macrophages, but your monocytes are produced in your bone marrow. They enter circulation and they migrate to that inflammatory site where they develop into macrophages. So these are phagocytes, but they typically get to that inflammatory site or that area of injury as soon as 24 hours, but it's usually a little bit later than neutrophils. So just when you think about looking at your patient's blood work, that's why obviously when you have an acute infection or significant inflammation going on, initially you're going to see a rise in neutrophils in that patient's CBC. And macrophages usually occurs a little bit later, in comparison to neutrophils. Activation results in increased size, plasma membrane area, glucose metabolism, lysosomes, and secretory products. So it's all part of that innate immune response. Neutrophils, sometimes you'll hear them as PMNs or PMNs. So that's very predominant in that early inflammatory response, so that first 6 to 12 hours. So that's why a lot of times you'll see a rise. Once again, they can ingest bacteria, dead cells, cellular debris, and this is really what creates exudate, essentially, when the body's ridding of it, the dead cells or bacteria from the body. They become a component of the purulent exudate. So anytime you see that, that's basically from neutrophils and all that with, phagocytosis, essentially. It can remove debris in a sterile environment, so meaning that it can remove other debris from that area, even if it's not bacteria. So obviously, it kind of cleans up the area. Eosinophils, you'll see this more with like a parasitic infection. They regulate vascular mediators from mast cells, so they're heavily linked with mast cells. Eosinophils, we'll talk about this later, but they tend to rise a lot in allergies. So if you have a patient that has, significant allergies, significant asthma, or like a flare of it, sometimes their eosinophils will be elevated with that. So it is heavily linked with more of that allergic component too. Whereas neutrophils, you'll see that more with like infection and inflammation. Basophils, the role is kind of uncertain, but there is, an important link with cytokines, essentially. Which is a regulator of your acquired immune response. So there's a link between the two and kind of stimulating that acquired immune response there. I'm sure you're well aware of platelets. I think you understand what that is, but obviously it's activated by tissue destruction and inflammation. So really that starts that clotting cascade in that area to stop bleeding, which I'm sure you're well aware of. So your dendritic cells are part of your innate immune response. However, it creates that important connection between your innate response to acquired immunity. So they're almost like a cell presenter, essentially, or antigen presenter, I should say. And this is what stimulates the development of antibodies, once we start moving into an acquired response. So they migrate, once they're actually present within your organs and your skin, but they migrate through your lymphatic vessels and your lymphatic tissue and actually interact with T lymphocytes, which we'll talk about, in the second lecture. But that's essentially what presents it and then stimulates that acquired immune response. So once again, I just put that image down there, with innate versus adaptive immunity. You also have natural killer cells. Essentially what these do is recognize and eliminate cells infected with viruses. So these are ready to attack essentially once they're formed. So it basically can recognize, these pathogens versus your own normal self cell. Because obviously, we don't want the innate immune system to go haywire and attack normal cells. So in this case, it actually can recognize, that it's non-self essentially and actually kill these cells, whether it's an infection or a cancer cell. And it damages them essentially, or damages the cell membrane, or releases enzymes to create damage. It also produces cytokines, which actually regulates part of your acquired response with B and T cells. It can produce toxic molecules, so it's an important first line against first line defense against viruses, essentially. And I just added the image below because on your cells, like your normal self, we have these MHC, which are major histocompatibility complexes, essentially, that are on cells. And really, it can recognize whether it's normal self versus a pathogen like a virus or something like that. So essentially, that's why I just added it, so that way you understand that it's not attacking self-only viruses, essentially. This is just the same thing that I was just mentioning. A natural killer cell recognizes those major histocompatibility complexes on healthy cells and it won't attack it. But once again, if it's an infected cell, it can basically attack it because it doesn't have those complexes on it, essentially. This is the same exact thing that I already mentioned between your innate and your dendritic cells basically interacting, and then you have B cells, T cells, which we'll talk about in the next lecture. Cytokines are a big portion of your innate response. You have interleukins. There's many, many different ones. I don't expect you to memorize these by any means. Just understand that the cytokines essentially are part of your innate response. But interleukins are produced by macrophages, lymphocytes, and once again, it's usually when you have this inflammatory process that stimulates it. And it enhances the acquired immune response, so it helps that communication there. Many, many different types. There's some that are pro-inflammatory and some that are anti-inflammatory. There's also interferon, which is actually considered a cytokine as well. And this typically protects against viral infections and modulates that inflammatory response. So it kind of sends that signaling there for inflammatory response. It's produced and released by virally infected host cells in response to viral double-stranded RNA. It doesn't directly kill, but protects the healthy cells. So what it actually does is it's actually produced, so these infected cells will produce this essentially, and it will help the other cells that are not infected. I have a good image on the next slide, but essentially will help protect the other cells from not being invaded by the bacteria, essentially. So it's more of a protective mechanism, essentially. There's different types. Once again, there's many. Interferon, alpha, beta. You don't need to memorize all these. But basically, they produce antiviral proteins, so it protects those uninfected cells. So it's actually kind of a protective mechanism. Increases biocidal activity of macrophages, so it has an impact on that as well. This is just what I meant when we talk about interferon. So you have, on the very left, a cell that's infected with a virus, because remember, that's kind of what happens with viruses. So it releases these interferon molecules, and obviously it can actually help protect the ones that are not infected. So it actually kind of binds on receptors on the external portion of the cell. And basically, it's almost like an antiviral protein that it protects. So it's protecting it. And it'll block that virus from invading that cell essentially. Or it'll invade, but it'll basically block replication of, viral nucleic acid synthesis in that new cell. So it protects other healthy cells essentially. TNFA, you actually will see this a lot too, like when we talk about like autoimmune diseases, because we actually use a lot of medications like biologics that actually work at this area. And tumor necrosis factors actually, it's secreted by macrophages in response to these receptors. Essentially, when you see PAMP and toll-like receptors, these essentially are on pathogens, and it'll kind of stimulate this response of TNF-alpha release. But it has, significant interplay with inflammation in the body. It also can, induce fever in patients as well. And we'll kind of talk about this more when we move into like autoimmune disorders. But this actually increases those proteins in the liver, which is another factor that we kind of look at. And I have it on another slide, but we'll look at a lot in terms of laboratory testing. We'll look at like a CRP level or even a SED rate in individuals. And I'll talk to you about this as we move through like hypersensitivity reactions and stuff like that with autoimmune disorders. But when you have massive inflammation throughout the body, you start to synthesize these proteins in the liver that you can actually detect by blood. However, they're not specific. So when you get an elevated CRP or an elevated SED rate, it doesn't always, it doesn't point to one underlying disease state, essentially, is what I'm trying to get at. But if you have a patient, for instance, that had like an autoimmune disorder where they have massive inflammation going on, it's not uncommon for them to have, an elevated SED rate. And this is exactly why, because of these, cytokines or TNFA stimulates release of these proteins in the liver. So that's why sometimes you'll see that in patients' blood work. It also has an interplay with muscle wasting, cachexia. Intravascular thrombosis is a consequence of prolonged production and severe infection and cancer. So really, when you think about even those cancer patients or a severe infection, think about that risk of having DVTs and clots. Because once again, this massive inflammation changes things, and they can actually be at risk for um, thrombosis. So if you think about it from a broad perspective, you can see the link there essentially with it. Because we always talk about like cancer patients, and there's a multiple factors too, obviously, just besides this, but, being bedridden and all that, or decreased activity, but, they're at risk for clots and all that as well. Acute obviously is acute. It's self-limiting, so there's usually, they'll resolve. But it's usually they'll have that pain with it, and that's from prostaglandin and bradykinin presence. So a lot of times they have that redness, heat, swelling. Exudate, you may notice obviously at the area, and I'm sure you've all seen this at, some point or another. And I'm sure you're well aware of like the fluids that you see, like whether you have serous exudate, which is that more watery exudate. And that's a very early response to inflammation. So it's more of the fluid that you're seeing because of the vascular permeability there. You may see fibrinous exudate, which is basically has factors that from the clotting cascade essentially in there, or fibrin. So it's more advanced inflammation because you're starting to get that clotting in there as well. Purulent exudate, I'm sure you've all seen this, so when you see things that have an infection, you're going to start to see pus there. And remember, it's because of all that neutrophil, phagocytosis in that area, and that brings it to the skin surface, and that's when you get pus. And it's not just the skin. I mean, you can even think about other areas like the chest, the respiratory tract. It's not, they may get mucus production essentially from that area. And it's all, you got to think about it from the broad perspective too, not just like a skin infection. But essentially, this is kind of, how it occurs. Hemorrhagic exudate obviously is more blood. Obviously, that's more if there is more bleeding in that area, and you lose control of the bleeding process there, or clotting process. Some other systemic manifestations of acute inflammation. So once again, when you start to see fever, it's not uncommon in kids for them to have a fever with, like a virus or upper respiratory infection. But once again, when you see a fever, it's, showing you that there's a systemic process going on there. So there's systemic inflammation that's triggering it. And once again, we kind of talked about fever with temperature, and it's usually related to all these chemical mediators like prostaglandins or exogenous or endogenous pyrogens. So remember things too, like bacteria or viruses can release things like this. There's certain bacteria that are more known to release, endogenous pyrogens, or I'm sorry, exogenous pyrogens. But once again, it, acts directly on your hypothalamus. Leukocytosis, when you're looking at your patient's CBC with differential, you're going to see elevated white counts in these patients. And it's not uncommon to see, neutrophils that are elevated. You probably have heard of a left shift. So if there's severe inflammation going on or a severe infection, in order to keep up with it, they start to release immature leukocytes or bands. So you hear that term left shift there. That's usually with an acute inflammatory process. Increased plasma proteins, and like I just kind of mentioned, and I actually have it on the next slide because I wanted to make sure I pointed it out. So acute phase reactants. So if you have a significant inflammatory process going on or infection, sometimes these reactants will rise. For instance, like I've worked in orthopedics a lot, and they will commonly look at like a CRP level or even a SED rate. Like if they had an major orthopedic surgery or they had a hip replacement and they're having issues, and we're worried about infection, that is one lab value that you definitely will look at is like a CRP level. And I'm sure you probably have seen these in the hospital, depending on where you work. But even thinking about it from another broad perspective, you think about heart disease. All of these disease states, heart disease, all of that is linked with inflammation. Inflammation, is heavily linked with a lot of different disease states. So an elevated CRP level has been linked with, cardiovascular disease. So things like that. It's not just necessarily like when you think about an injury, it's other chronic disease states that can increase these as well. A lot of time we'll look at the other one that in primary care, we tend to look at like CRP levels or SED rates. But there's other ones, obviously. I don't expect you to memorize all of those. Just essentially know about the C-reactive protein and SED rate, because those are ones that you'll definitely run into contact with in clinical practice. I added this, once again, like a high CRP. These are not, one thing that you have to realize with these when you're checking these is that it's not a direct indicator to one disease state, meaning that you can't always attribute it to the one disease state you're looking at. It could be from multiple factors that are elevating CRP levels, or a SED rate. But they just keep in mind it is one thing that you can utilize for diagnostic testing to kind of help differentiate between what's going on or a potential cause there. So CRPs are associated obviously with systemic inflammation, but it can be things from like diabetes, metabolic conditions. But once again, it's associated with an elevated cardiovascular risk. It can be elevated with long-term infections. So once again, it's not to pinpoint on one disease state, but it's used, to supplement your diagnostic or clinical reasoning there. Your SED rate. We use a SED rate a lot in autoimmune disorders. For instance, if you have a patient that you're caring for that has rheumatoid arthritis, sometimes we use it as not only as a mechanism to help, determine whether there's, systemic inflammation there, but we also use it as a gauge in terms of treatment. So it's not precise once again. So you have to kind of put it in perspective. But let's say you have a patient with rheumatoid arthritis and you start them on a biologic agent. And I don't expect you to know all this right now, but you put them on a new treatment. Sometimes, obviously, when they come back, we'll draw their SED rate again. We'll look at that pattern in their SED rate. Like, are they improving symptom-wise, and is their SED rate better, or is it worse? So it's a good gauge in terms of how much inflammation is going on. So you do see a SED rate used pretty frequently in the outpatient setting, especially with rheumatologic disorders. Kidney diseases, because once we get into hypersensitivity reactions, that can be related to an autoimmune process as well. But response to therapy, like I just mentioned as well. And we'll talk about all these, disease states as we move through the class. Chronic inflammation obviously is 2 weeks or longer, so it's chronic. And it's usually related to an unsuccessful acute inflammatory response. So, there's just not well control there, essentially. But this, obviously, when you think about like a local level, can affect wound healing when you're thinking about like an injury to the tissue. And that's really when you get incomplete wound healing or granuloma formation or scar tissue formation in that area, essentially. So there's usually with chronic, you'll have like a dense infiltration of lymphocytes or macrophages in the area, granuloma formation, epithelioid cell formation or giant cell formation. And I don't expect you to remember all these different characteristics here, but like an example for this would be even TB. Like, remember when we were talking about looking at changes, and sometimes you'll see it when we were talking about necrosis or something, in that first lecture about kind of walling it off, and actually they form like a granuloma. So TB is kind of a good example of this. So even things like that infectious process obviously turns into a chronic state, and they start to have, this granuloma formation, in the lungs. So TB is a good example of it. I'm trying to think of another one. Even different fungal infections can cause it. Syphilis is another one that you might see it with. But essentially kind of helps wall it off and contain that area. But that's more with a chronic state that you'll see that. So obviously, too, inflammatory responses are very, very linked with chronic illness. Things like diabetes, cardiovascular disease. All of this has a very significant impact on it, or inflammation has a significant impact on it. So as we move through different disease states, really try to think about that too. But once again, in the older adult, these are things that contribute too. So their inflammatory response can be affected too by chronic disease states. So they may not have a great inflammatory response, or innate immune response as they did when they were younger. Medications can obviously decrease the inflammatory response, whether, they're on corticosteroids or just different agents that can decrease that immune response. They have a decreased healing response, so just things like with changes with their skin and those inflammatory mediators, essentially. Infections are much more common in older adults, and obviously, too, it's related to their immune system as well. So this is just the first section. So in the next one, we'll talk about adaptive immunity, and I'll kind of explain how they interact. And then, so just take a look at that one next. Thanks, and I hope you have a great day.